Good evening. I'm Dr. Shabeen. I'm a consultant nephrologist working in a Baby Memorial Hospital, Kannur, Kerala. Today, I'm going to discuss the role of Cilnidipine and Telmisartan combination in hypertension and comorbid diabetes. As we know, the hypertension is prevalent in most individuals with diabetic kidney disease. The failure to treat the hypertension appropriately in this subgroup of patients results in an increased risk of cardiovascular morbidity and mortality, as well as the faster progression of kidney disease. The failure to treat hypertension appropriately in this subgroup of patients results in an increased risk of cardiovascular morbidity. And this is in large part the result of the strong association of DKD with CVD outcome, such as, wait a minute, getting a call, sorry. Yeah.
Yes, sir, take your call.
It's not only the mortality this is of concern, but also the morbidity and high overall cost of care related to DKD, that is diabetic kidney disease. This is in large part the result of the strong association of diabetic kidney disease with cardiovascular disease outcomes such as heart failure, stroke, myocardial infarction, and end-stage renal disease. There are multiple mechanisms in the development of hypertension in patients with DKD, as we know. This includes the RAS activation, inappropriate activation of the RAS, and the sympathetic nervous system, and the volume, increased volume, and also the peripheral vasoconstriction, and also the upregulations of the molecules like endothelin 1, and also the development or formation of the reactive oxygen species, and also the downregulations of nitric oxide. Many of these factors accelerate the development of the kidney disease and increase the risk for the cardiovascular disease among people with diabetes and hypertension. Thus, they serve as target for risk reduction by managing the hypertension. Till now, there are no randomized or multicentral control trial available to address the appropriate BP targets in patients with DKD. But the target BP for patient with diabetes is commonly used as an alternate. That is, 130/80 is usually recommended. In addition, the ADA consensus panel point out the relevance of 24-hour the ambulatory BP measurement to identify at-risk subgroup of patients with diabetes, such as those with masked hypertension and nocturnal non-dipping status, as possible confounders of the relationship between the office-measured BP and DKD progressions. The emphasis on the treatment of hypertension in patients with DKD should include strategies that address multifactorial risk factors reductions and include the pharmacotherapy, of course, the lifestyle modification, and patient education to improve the self-management of these complex risk factors. The sympathetic stimulation in the renal efferent and efferent arterioles increase the resistance and decreases the renal blood flow. The renal ischemia will cause further sympathetic activation, releasing the process substance such as norepinephrine and renin, relating to the aggravated hypertension. The cilnidipine is as we know, is a derivative of dihydropyridine and possesses the property of blocking both the L and N-type calcium channels that are present on peripheral nerve endings, inhibiting calcium release in sympathetic nerves and release of norepinephrine. The N-type calcium channel play a vital role in neurotransmitter release from sympathetic nerve endings, and blocking it may suppress the overactivity of the cardiac sympathetic system. In addition, the cilnidipine was more effective in reducing proteinuria or preventing its progression and had similar effect on creatinine and eGFR in the hypertensive patient in comparison to L-type calcium channel blocker. Another drug, as we know, the angiotensin 2 receptor blocker like Telmisartan, which is most commonly used in India for RAS inhibition to reduce albuminuria, cardiovascular risk, and progression of DKD, is well supported by a number of clinical trials. The Amadeus study showed that Telmisartan is more effective in reducing proteinuria in hypertensive patient with diabetic nephropathy because it is a partial agonist of peroxisome proliferative activator receptor gamma as well as angiotensin 2 type 1 receptor. Another study that is Jinaga demonstrated a direct dose-dependent renoprotective effect of Telmisartan. So the higher the telmisartan dose, the results in a decrease in the amount of urinary protein. So the combination of these two, that is the calcium channel blocker, which is Cilnidipine, and ARB, which is telmisartan, can provide the additive and synergistic effect in lowering the blood pressure, potentially thereby improving the kidney function and reducing the proteinuria in renal hypertensive patient. Thank you.